Getting providers to stop doing things is probably more difficult than getting them to innovate. We worked in infection control in the early 1980s and tried to get in the OR the tacky mats that were at the entrance and exit of the operating room that was supposed to pick up germs, et cetera, on your feet. They actually spread more infection than they prevented. And it took 15 years to get Hopkins to get them out of the hospital. So it's really a very difficult thing. Okay, so next up is Liz Selvin. She's an associate professor in the department, and she is one of the principals in the Welch Center. If you may remember, the Welch Center is a joint effort of the Department of Medicine and the Department of Epidemiology focused on clinical and prevention aspects of disease. And Liz is an extremely highly published author and is basically, I refer to her as the queen of hemoglobin A1C. She has had incredible impacts on guideline development in the area of diabetes. So next up.
All right, well, thank you very much, and I won't disappoint you. I'll definitely talk about hemoglobin A1C. It's hard for me to talk about anything else. Okay, so I'm a diabetes epidemiologist, as David said, and I'm going to put on this microphone because I know you can't see me if I stand behind here. And I study a lot of topics, but this is actually, a debate that has been really interesting to me. It's not something that I set out to address. It's a debate that I was kind of pulled into by virtue of the type of work that I do. And I'm gonna show you a little bit about the work we've done to address this controversy. So just to begin, so these are the tests for diabetes that we're used to seeing and thinking about in the setting of diabetes in clinical practice. So fasting glucose, which is a direct measure of the concentration of glucose in your blood, measured typically after an 8 or more hour fast. And then there's glucose measured after a carbohydrate challenge. So you can measure glucose after you've drunk one of these awful icky drinks over here, and to get a sense of the body's response to the glucose, the carbohydrate challenge. And then there's hemoglobin A1C, as David alluded to, my favorite molecule, which is an indirect measure of hyperglycemia. So it reflects glucose control over the past 2 to 3 months, because glucose binds to hemoglobin in your red blood cells, and because your red blood cells turn over approximately every 120 days, you can measure the proportion of hemoglobin that's been glycated or has glucose bound to it to get a sense of the average exposure to glucose over the previous 2 to 3 months. And so these are the 3 standard tests that we're used to thinking about in the setting of diabetes. And hemoglobin A1C, I should mention, has for decades been the standard measure that we use in clinical practice to monitor glucose control. And so in 2010, actually in 2009, an international expert panel, and then in 2010, the American Diabetes Association first recommended the use of hemoglobin A1C as a diagnostic test for diabetes. So this is a major change to clinical practice. And so, and you can see here, these are the criteria for the diagnosis of diabetes, first published in 2010, and now in our standards of medical care for diabetes. And you can see hemoglobin A1C here at the top of the list, added to fasting glucose and 2-hour glucose as a test for diagnosis of diabetes. And as I mentioned, this is a really controversial change. And for those of us who study hemoglobin A1C and have for many years, and I think it's a really useful test, the controversy was rather interesting, and I was really struck by the sort of the blowback and the issues and concerns surrounding this recommendation, because to me and to a lot of others, this made a lot of sense. And that's because there's a lot of advantages to hemoglobin A1C as a test for the diagnosis of diabetes. So one of the major challenges was standardizing this assay. And this assay is now very well standardized thanks to the efforts of the National Hemoglobin Standardization Program and other programs across the world. It's a better index of overall glycemic exposure, right? It's this integrated average measure that provides a lot of useful information in a particular patient. It's actually a better predictor of outcomes as compared to fasting glucose. And it has much less day-to-day within-person variability, right? My hemoglobin A1C today is likely to be identical or very, very similar to my hemoglobin A1C measured a couple of weeks from now. And that's not true with glucose measures. It eliminates the need for patient preparation, right? People don't have to come to the clinic in a fasting state. And then unlike glucose, it's relatively unaffected by recent physical activity or illness. And it's already used, right? We've been using it for decades to guide and adjust treatment in the setting of diabetes. So for a lot of us, recommending hemoglobin A1C as a diagnostic test made a lot of sense. So what was the controversy about? So some of the things that people, or some of the issues related to the use of hemoglobin A1C for diagnosis is there are some things that interfere with the assay. Okay, but that's known. And actually modern assays are largely not subject to these types of interference, and that's something that's documented. The labs are aware of it, physicians are aware of it, and we understand this. There's some conditions in which the hemoglobin A1C test is not accurate. That's true with all lab tests, right? So, and that needs to be, addressed. And we know that in pregnancy, if you've had recent blood loss, or you have altered red cell turnover, that the test should be interpreted, may not have the correct interpretation. So cost, that was a major controversy, and that's important, right? And we know that in resource-poor areas, hemoglobin A1C may not be the first-line test. But we weren't taking away, this wasn't a substitute for glucose, right? It was being added as an option for use in diagnosis. And then finally, I think this is part of the controversy, is that right now we have 3 tests for diagnosis of diabetes, and they measure different things. And they're not completely concordant all the time. So you're going to get different results depending on which test you use. And they may identify different people. And so that's something that has to be resolved and is important. And then finally, a very controversial area, which is what I'm going to spend the rest of the time talking about, is that African Americans have higher hemoglobin A1C values compared to whites in our big epidemiologic cohorts. And so it was really kind of shocking to me that repeatedly, when these new recommendations came out in 2010, this was repeatedly cited as a limitation of hemoglobin A1C as a test for diagnosis of diabetes. And so just one example. So this is a review on diagnosis of diabetes that was published in the New England Journal in 2012. And so you can see here, so just as I mentioned, so fasting glucose, 2-hour glucose, hemoglobin A1C as our diagnostic test, and then the author lists some advantages and disadvantages. And among the disadvantages, so lack of reliability in certain conditions, altered red cell turnover, and then here you can see racial and ethnic differences, slightly higher levels in blacks. So listed as a disadvantage of the hemoglobin A1C test. Okay, so when I was a kid, Sesame Street had this segment, which was one of these things is not like the other. I'm not going to sing the music, but remember the segment. Maybe they still have it, I don't know. But there's this segment, and they would put up a series of things, and then you had to decide which one of these things is not like the other. And so I think if we apply that type of thinking here, I'll put up a list of these cited disadvantages of hemoglobin A1C as a test for diagnosis of diabetes. So we've talked about assay interferences, conditions that interfere with the hemoglobin A1C test results, its expense or costs, the fact that not all these tests are going to be completely concordant, and then the higher levels of hemoglobin A1C in African Americans. So which one of these things is not like the others? All right, so Elmo says higher levels of hemoglobin A1C. Actually, they didn't have Elmo when I was a kid. But so I'm going to spend the rest of the time talking to you, hopefully convincing you that I really don't think that this statement belongs as a cited disadvantage of hemoglobin A1C as a test for diagnosis of diabetes. Okay, these are some data. They're older data from 1999. I did that on purpose, just showing you that we've known for a long time that blacks, on average, have slightly higher hemoglobin A1C levels compared to whites. And so this is data from the National Health and Nutrition Examination Survey, so nationally representative sample of the U.S. population. and then looking in people with normal fasting glucose, impaired fasting glucose, undiagnosed diabetes, and then people with diabetes who are men, and then women with diabetes. And you can see in each of these groups, there's slightly higher hemoglobin A1C levels in blacks compared to whites. So we've known this for a long time. But so it was interesting to me that on the heels of this recommendation for use of hemoglobin A1C for diagnosis, that there was these really strong statements being made by experts in the field about this, interpreting this as a limitation of the tests in the clinic for diagnosis. So just an example, so from the British Medical Journal, as ethnic differences in hemoglobin A1C are independent of glycemia, hemoglobin A1C may be limited in diagnosing diabetes across the general population in the UK. Annals of Internal Medicine, black persons have higher A1C levels than whites. This finding could limit the use of hemoglobin A1C to screen for glucose intolerance, indicate risk for complications, measure quality of care, and evaluate disparities in health. Just two more examples here. Hemoglobin A1C values are misleading as a measure of average blood glucose among persons of African, Asian, Hispanic, and other non-European ancestry. Hemoglobin A1C for diagnosing diabetes or prediabetes is ill-advised. And finally, A1C may not be valid for assessing and comparing glycemic control across race and ethnic groups or as an indicator of healthcare disparities. Okay, and this is just some examples. So many statements like this being made that hemoglobin A1C may be problematic for diagnosing diabetes in minority groups. So one point I want to make before showing you some of our data is that central to this debate is whether factors that contribute to higher hemoglobin A1C in blacks versus whites are glycemic or non-glycemic. Okay, and so what do I mean by non-glycemic? So I mean factors that contribute to alterations in these tests of glycemia, like hemoglobin A1C, through pathways that are independent of hyperglycemia itself. Okay, so things that are independent of the factors that put you at risk for diabetes in the first place. So what are the postulated non-glycemic factors? And this is why, and this has been the postulated explanation for the higher hemoglobin A1C levels in blacks compared to whites. So the things that we see in the literature are red cell turnover, red cell permeability, and the tendency of hemoglobin to undergo glycation. So there's absolutely no direct evidence that these things differ across ethnic groups. But unfortunately, these are things that are very difficult to measure or impossible to measure in population-based studies. So we don't have direct evidence to understand whether these things are different or not. But these are the postulated non-glycemic factors. Okay, so if the higher hemoglobin A1C in blacks is a result of such non-glycemic factors, right, this suggests, as some of the statements that I just showed you alluded to, it means that hemoglobin A1C is sort of quote-unquote artifactually or falsely high in blacks compared to whites, right? It suggests that apparent disparities in care are potentially not real. It suggests that reducing this disparity might do harm, right? The logical conclusion is that this would result in overdiagnosis. These values are falsely high, right? And then if we treated blacks to the same targets that we do in whites, right, that potentially result in hypoglycemia because we're not getting accurate measurements of hemoglobin A1C. And then several leaders in the field have suggested, well, this means we need a race-specific treatment target, and we need race-specific diagnostic thresholds. So this was all very interesting to me and really concerning that these very strong statements were being made with very little evidence to support them, is what I felt. So I was very interested in bringing evidence to bear on this debate. So I'm an investigator of the atherosclerosis risk and community study, and actually I have been since I was a PhD student. I've been collaborating with the ERIC investigators. And this is a wonderful and really rich resource for addressing epidemiologic problems and clinical controversies like this one. So it's an ongoing community-based cohort of over 15,000 middle-aged adults. So they were originally enrolled from 4 communities in the United States in the late 1980s. And then they were seen at multiple time points, and we just completed a 25-year visit of all of the living participants. And then we've had continuous contact and surveillance of this cohort over this time period. And one of the characteristics of ERIC is that 25% of the participants are African American. One of the and so as part of some of my work in ERIC, we measured a number of things, but one of the things I was interested in measuring was hemoglobin A1C. And so we measured hemoglobin A1C in all of the ERIC participants using stored blood samples, and then looked at the subsequent risk of complications. And so these data were published on the heels of the American Diabetes Association's recommendation for use of hemoglobin A1C as a diagnostic test, and were really valuable in showing the interpretation of hemoglobin A1C with respect as a prognostic indicator of future risk. And so this work was done in collaboration with Dr. Fred Brancati, Joe Korish, and Mike Steffes at University of Minnesota, who's been my long-term laboratory collaborator. And so one of the things we did is looked at hemoglobin A1C as a prognostic marker of long-term chronic conditions, cardiovascular disease and stroke. We looked separately in blacks and whites. This being the New England Journal, they have a 2,700 word limit. They're very serious about that word limit. So our entire paragraph discussing the results in blacks compared to whites was reduced to about 2 sentences. And that's likely because the paragraph demonstrated there were no differences between blacks and whites in terms of the prognostic value of hemoglobin A1C. So this is a null result. Our results are similar in blacks, similar in whites, okay? So because this continued to be an issue, we published an entirely a separate paper. It was kind of a redo of that analysis, looking separately in whites and blacks. And I don't typically put the conclusions of my paper in the title, but I think I was just really trying to hammer home this point. So no racial differences in the association of hemoglobin A1C with kidney disease and cardiovascular outcomes. Okay, so this is a null result, right? No difference. And it's hard to get a lot of traction for a null result, right? It's much more exciting to show differences than it is to show lack of difference. So I want to just show you briefly some data here. So this is the ERIC population from these studies. So this is this is a group of whites, and this is a group of blacks without diabetes. So what do you notice here? So hemoglobin A1C is slightly higher, as I showed you. What else do you notice? Right, everything is different. Right, and actually everything here is statistically significantly different when you compare blacks and whites, except for LDL cholesterol. Right, triglycerides are different, HDL is different, BMI is different, physical activity is different, smoking, hypertension, right? There's a lot of differences. So maybe this higher hemoglobin A1C wasn't such an unexpected finding, okay? And so as I mentioned, right, so we found blacks have higher hemoglobin A1C compared to whites, but the associations with complications were similar, right? Okay, so this was looking at cardiovascular disease and kidney disease. Okay, which were important complications of diabetes, but many people get kidney disease and cardiovascular disease. And it turns out retinopathy largely forms the basis of our current clinical cut points for thinking about markers of hyperglycemia in the setting of diabetes. And retinopathy is highly specific to diabetes. So we said, okay, well, let's look at black-white differences in the association of hemoglobin A1C with retinopathy. So this study was led by Julie Bauer, who was a postdoctoral fellow with me at the time. And so again, this is the second paper where I put the conclusion of the paper in the title. No ethnic differences in the association of glycated hemoglobin with retinopathy. So we found that while blacks had a higher prevalence of retinopathy compared to whites, the association or the predictive value of hemoglobin A1C was the same in blacks compared to whites. Again, a null finding, no difference. And then finally, in thinking about sort of what other data we could bring to bear, because I still, this wasn't exactly silencing these vocal critics, we measured a bunch of other markers, so serum glycemic markers that are unaffected by hemoglobin or red cell characteristics. So I'm not going to go into detail, but we measured fructosamine, glycated albumin, and something called 1,5-anhydroglutatol in ERIC samples, and looked at whether there were black-white differences in these markers. And what we found is the black-white differences in these serum glycemic markers parallel those differences we saw for hemoglobin A1C. So we said racial differences in hemoglobin glycation and red cell turnover cannot explain the racial disparities we see in hemoglobin A1C, because these other markers are independent of hemoglobin, independent of characteristics of the red blood cell. So we said, which I think was, I think is what the evidence actually suggests, higher hemoglobin A1C in blacks may reflect a high risk state. And then finally, this last publication, so this came out last month, so hot off the press, and we looked at trends in the prevalence of diabetes over the past 20 years in the United States. And I'm not going to go into detail this study, but one of the things that the main finding is that we've seen a huge increase in diabetes over the past 20 years, as probably most of you know, and this tracks very well with the epidemic of obesity. And so there's now 20 million adults with diabetes currently in the United States. But one of the things that we showed in this paper is there are major racial disparities in who is affected by diabetes, right? So you can see blacks much more likely to have diabetes compared to whites, and Mexican Americans also more likely to have diabetes compared to whites. So the implications of saying that a particular diagnostic test doesn't work or shouldn't be used or should have a different interpretation in racial and ethnic minority groups who have a much higher burden of the disease and are at higher risk for complications, has really an important impact. I mean, that is a very, very strong statement, and I think it should be backed up by evidence. And hopefully what I've showed you today suggests that evidence does not support that statement. So I think the implications of the racial disparities that we see in hemoglobin A1C are that these racial differences are likely to reflect true differences in hyperglycemia. We've seen that blacks and Mexican Americans are at higher risk of complications as compared to whites. I think the differences in diet, physical activity, and other lifestyle factors may contribute to higher non-fasting hyperglycemia in racial and ethnic minority groups. And this is where we should focus attention in understanding these issues, which we typically don't measure very well in epidemiologic studies. So I think the other implications means we need to improve care and health behaviors. It suggests there's no need for a race-specific treatment target. There's no need for race-specific diagnostic threshold. And if we reduce the disparity in hemoglobin A1C, this should actually improve health. And in terms of overarching conclusions, a couple of the other things I wanted to mention, that I think these results really suggest and demonstrate the importance of large and diverse epidemiologic cohorts to inform major clinical controversies in chronic disease. So none of this work would have been possible in administrative databases, right? We really needed the rigorous and standardized in-person data collection that they have in the ERIC study. I've made liberal use of stored biospecimens. None of this would have been possible without being able to go back and obtain the stored whole blood that had been collected in 1990 and measure hemoglobin A1C 15 years later. And then, of course, we had long-term follow-up for adjudicated events, which is really critical. And it suggests the overall importance of linking new diagnostic tests to long-term outcomes. And a bunch of our new areas of research, this is really the goal. We have these diagnostic tests that are coming out, and we really need to understand what they mean in terms of long-term outcomes. And that's where epidemiology has its strength. And this type of work is really the key to understanding racial differences. And as David already mentioned, these data particularly have informed clinical guidelines and how we interpret various diagnostic tests. And so this type of research is only possible with big teams and lots of people. And I've really had the great fortune of working with an incredible team. And so just some of them are listed here. So my mentor, Fred Rampati, who passed away last year. None of this work would have been possible without Joe Koresh and Mike Steffes. Joe Koresh is a colleague of mine in the Department of Epidemiology, and Mike Steffes is my lab collaborator at the University of Minnesota. I mentioned Julie Bauer, who was a postdoctoral fellow at the time that we collaborated. She's now an assistant professor at Ohio State University. Christina Paranello was a co-author on the recent paper and is working with me to continue some of these areas of investigation. And of course, many, many, many co-authors, too many to list here. And most importantly, the ERIC study staff and participants, without whom none of this would be possible. So thank you very much for your attention.
Dr. Selvin, this is very interesting and out of my area of knowledge, but here's a few things I know, and I wondered if you could answer. First of all, that the interaction of glucose with amine groups is non-enzymatic. So the hemoglobin AC is a non-enzymatic fish shift base between the aldehyde of the sugar and the amine group of hemoglobin. Now, it also does that on dozens of other proteins throughout the body. And when those proteins are long-lasting connective tissue, it's been associated with aging. They call it advanced glycation end product. So what I want to ask you is the following. Is there a possibility that you could look, and I'm sure this has been done, at the protein pattern, like a proteomic pattern of an African American versus a Caucasian, and see a glycation pattern other than the hemoglobin, which turns over in 120 days, but some of the collagens and other things are very low. I know you're well aware of this. I wondered if you'd comment on it.
Yeah, sure. Thank you. That's great thoughts there. So yes. So I mean, I think that one thing is, and because I'm not a clinical chemist, but my clinical chemistry colleagues tell me, right, it's a non-enzymatic reaction. Why would it differ across racial groups, right? I think that's one statement that you made that I think is important. So before we start attributing these things to biological or physiologic differences, I think it's important to understand whether we think that's actually possible. So I think there's a lack of evidence that glycation as a process would differ across racial groups in any meaningful manner. I think the issue of advanced glycation products is very intriguing, and I've thought about that for many years. One of the difficulties with advanced glycation products is you can't measure them easily. So so the advanced glycation of collagen, for instance, right? You need tissue samples. So very hard to do in large population-based studies. And then the assays have not been well developed. So it turns out there's lots of advanced glycation end products. So figuring out which one to measure and which one is meaningful turns out to be really complex. So I think that the evidence really isn't there. And we've looked at genetic studies and proteomic studies, and we don't see systematic differences in terms of glycation and glycation products in blacks and whites. So I think I think it's that there's been a conflation of genetic evidence. There's genetic evidence that determines glucose levels and determines hemoglobin A1C levels, but there's been a conflation that would potentially explain racial differences because those genetic factors appear similar in blacks versus whites.
Are there gender differences?
Not big ones, no. There's big age-related differences, but I think again that's probably hyperglycemia. As you get older, more likely to have disruptions in glucose metabolism, more likely to have diabetes.
Do you know if anyone has attempted to separate the effects of race and diet?
So no, I mean I think diet is potentially really important here, but we don't have the capacity to measure diet very well in large epidemiologic studies. So I think that's one of the difficulties. Is it could be maybe this is all dietary differences, right? Maybe African Americans have higher go around with higher postprandial glucose levels due to dietary differences, and that's reflected in the hemoglobin A1C, but not in the fasting glucose. But we don't have the data, and there haven't been studies with like continuous blood glucose monitoring that could answer that have been done in both blacks and whites.
I work with a poor urban population in Harrisburg, Pennsylvania, and I'm based in a church, and I see folks come into the fellowship hall and pour 3/4 of a cup of coffee and 1/4 of a cup of sugar in it, which would kill me, I think, if I tried to drink that. But they are accustomed to a very, at least those folks there, and I'm sure that they are not a unique population.
Yeah, I completely agree. I think that the diet and lifestyle issues are really what we should be addressing, and I think it's been a distraction to focus on these differences in higher levels of hemoglobin A1C as a limitation of the test. And this is now out there in the literature, and every single report that I've seen, describes the advantage. They all cite each other, right? They all just show the advantages and disadvantages, and they all put race in there. And it's a very frustrating thing to me because I think it really reflects higher levels of hyperglycemia, suggests higher risk, and we should be targeting things like diet, lifestyle, exercise, other factors to try to understand the higher risk.
just real quick, what about shifting from corn sugar, the fructose, to the glucose? Does that change this?
Well, I think that whether fructose itself is contributing to racial differences, we certainly don't know. We don't have the data to address that. But sort of